Having finished paralytic squint, guys, we are starting with the other type of incomitant squint now, that is restrictive. I do hope you remember the classification. Incomitant is of two types, paralytic and then restrictive. I will like to ask you again, if you remember, it is diagnosed by which test? Restrictive squint is diagnosed by, anybody who remembers? No, we are not talking about the cover, uncover. We are not talking about those. A specific test which can be used to diagnose restrictive squint, which can be used to differentiate between restrictive and paralytic, everybody. Yes, very good. FDT, forced duction test, is positive in cases of restrictive squint. I hope you remember this. Yes. First of all, as a group, all the conditions can be diagnosed by this test. This group of squint is a rare presentation in your clinics. So there are lots of syndromes, small syndromes which come under restrictive squint. I will be discussing the two commonly asked or the two commonly presented syndromes in our clinics. The first syndrome that we discuss here is known as Duane's retraction syndrome. Okay. Duane's retraction syndrome is of three types and it has three clinical features. That is what I will write on the board. I will make a table for you, and then based on that table, we will try to understand and learn the clinical features of this. Let's start, everybody. Let's start to make the table for this, everybody. So, types are three: type 1, type 2, type 3. These are the clinical features which I am writing now. Clinical feature number 1, limitation of movement. Clinical feature number 2, B, retraction of globe. And third clinical feature, closure of palpebral fissure. Okay. Now, I'm just writing some letters, then I'll try to explain you the meaning of these letters, what I mean to say by these. First of all, let's complete the table. Let's learn this table, then let's understand this table, everybody. Okay. As simple as that. So, everybody, what is the first clinical feature? We are saying limitation of movement. Some movement is limited. Which movement is limited? I have written B. B means what, everybody? B means abduction. I have written D here, everybody. D means adduction. B and D means both abduction and adduction. The difference is only of a single letter between the two spellings, abduction and adduction. That's what I've used to make it easy for you to remember. Am I clear to everybody? How I remember this table, everybody? Let's see. Type 1, BD, BD, BD. You understand BD, everybody? If you have ever seen or taken histories, everybody, we usually ask, at least in North India and Central India, everybody, BD. Cigarette ka Indian version is called BD, everybody. Yes. So type 1 clinical feature is BD. Type 2, everybody, DD. DD, everybody knows, everybody. We deposit our fees of colleges in bank by our DD, demand draft, everybody. Type 3, BD, BD. So that's how I remember BD, DD, BD, BD. Easy to remember, guys. Am I clear to everybody? Type 1, BD, type 2, DD, type 3, BD, BD. Now, let's see. If you're talking about type 1, Duane's retraction syndrome, what are we saying? We are saying there is limitation of movement. Which movement is limited, everybody? Abduction is limited. That means abduction will not be able to occur. The affected eye will not be able to abduct or move out. Then, we are saying during adduction, everybody, during adduction, adduction will be able to take place. Yes or no? Yes. Limited is which action? Abduction. Here carefully. Abduction will be limited, not able to occur. Adduction will be able to occur. But along with adduction or the eye moving in, what will I be able to see? I will be able to see retraction of the globe. Globe means eyeball, everybody. Retraction means opposite of protrusion. Protrusion means eyeball coming out like Tom and Jerry. Retraction means going back in. Yes or no? So there will be retraction of the globe. The eyeballs will go in. And due to that, there will be closure of palpebral fissure. What is palpebral fissure? When I open my eyes, the opening between the two eyelids is called as palpebral fissure. Why are my eyelids able to remain open? If this is my eyeball, everybody, focus on my hand. This is my upper eyelid. My upper eyelid rests over the eyeball. So the eyeball is the bed of the upper eyelid. When there is retraction of the globe, everybody, retraction means eyeball is going inside the orbit. It is getting pulled in. So the eyeball is going in. So basically, somebody is pulling the bed below the eyelid. Yes? So as soon as the bed gets pulled back, the eyelid will fall down. When the eyelid will fall down, there will be closure of palpebral fissure. Am I absolutely clear? So that is why I've written the second and the third clinical feature together. Because as we are trying to say, retraction will lead to closure. Am I absolutely clear here? So let's see type 1 again. Limitation of abduction. Okay, abduction is not occurring. Along with retraction of globe and closure of palpebral fissure. Okay, everybody? During adduction. In type 2, we are saying limitation of adduction. Adduction is not able to occur. And whenever the patient is trying to adduct, I can try. Yes, I can try. You can't stop me from trying. And whenever the patient is trying to adduct, adduction is limited. And during that trying of adduction, retraction of the globe and closure of palpebral fissure is seen. In type 3, both the movements are limited, neither abduction nor adduction. And whenever the patient will try to do abduction or adduction, retraction and closure of palpebral fissure will occur. Am I clear to everybody? First of all, let's learn this. Once you've been able to learn this, BD, DD, BD and BD. Now, let me try to explain you a plausible explanation of why it occurs. Okay, everybody? So, type 1. Why it occurs. Type 2 and type 3 are not known clearly. Type 1, there is a plausible explanation. So, what occurs in type 1 is, lateral rectus gets innervated by fibers of third nerve instead of sixth nerve. Lateral rectus, the nerve supply is 6, SO4, LR6. But in certain cases, LR is supplied by the third nerve here. Paradoxical, everybody. Paradoxical. Opposite. Instead of the sixth nerve, it is supplied by third nerve. Now what will occur, everybody? Let's see. On impulse for abduction via sixth nerve, LR does not act. Yes or no? LR is no more supplied by the sixth nerve. So LR will not be able to act. When LR does not act, there is no abduction. Limitation of abduction. Am I clear to everybody? First clinical feature. Now everybody, second case, let's see here. On impulse for adduction via third nerve, both LR and MR contract. Both lateral rectus and medial rectus will contract because now both are supplied by the third nerve. Yes? So instead of the eyeball moving properly, what will occur, everybody? It will lead to retraction of globe. Why will it lead to retraction of the globe? Because both the eyeballs, the position of the tendon is from the eyeball to the apex of the orbit. So both the muscles are pushing posteriorly, or pulling rather, I can say posteriorly. So when both the eyeballs are pulling posteriorly, the whole eyeball gets retracted. Are you able to understand? The direction of force of a muscle is towards the origin. Yes, origin is at the annulus of Zinn. Insertion is on the sclera. So when both the muscles contract, they are pulling the eyeball from both sides backwards into the orbit. Retraction of globe, and that is why there is closure of palpebral fissure. I hope I'm pretty clear about this, everybody. Yes, that is the cause of type 1 DRS. Now, once you understand this, everybody, I hope I can end this topic by showing you a photograph. Let's see whether you can diagnose this. Everybody, primary gaze. First of all, what do we see in primary gaze? In primary gaze, we see whether the position of the eyeballs is normal, straight, or it is up, down, left, or right. So what can you see? Can you see any kind of problem, everybody? No, I can't see any problem. I see that primary gaze is normal. There is no deviation. As soon as there is no deviation, everybody, on primary gaze, what gets ruled out? What gets ruled out? Think about it. Paralytic squint gets ruled out. Yes or no? Because if there had been paralytic squint, there would be presentation of esotropia, exotropia, hypertropia, something like that. Now, let's see the left gaze, everybody. On left gaze. Left gaze, right eye is moving inwards. That means right medial rectus is functioning. But the left eye is not able to abduct. That means left lateral rectus is not acting. So I am writing no left eye abduction. Okay, stepwise, baby steps, everybody, as always. Now, let's see the right gaze. Let's see whether you can see any abnormality in right gaze. Right gaze, everybody. Right lateral rectus, functional or not functional? Functional. Left medial rectus, functional or not functional? Functional. Both the eyeballs are moving towards the left side. Then what is the problem? What is the problem? Can anybody see what is the problem? I'm just rubbing it for you so that you don't get distracted. Any problem anyone sees? No? I see a problem. This is the palpebral aperture of the right eye. This is the palpebral aperture of the left eye. So, can I say on right gaze, left eye adduction is present, but what is occurring? Left eye closure of palpebral fissure. Am I clear to everybody? So what does the question become now, everybody? There is limitation of left eye abduction. Okay? And on adduction, there is closure of palpebral fissure. So this becomes a case of type 1 DRS of the left eye. I hope there is no confusion in this simple topic, that is Duane's retraction syndrome. Done, everybody? Now, let's move on to the second syndrome, restrictive squint, which is known as Brown syndrome, everybody. Brown syndrome occurs due to congenitally tight superior oblique tendon. Okay? It is usually congenital, it may be acquired. But the fundamental which is going to occur is that there will be a tight superior oblique tendon. When the superior oblique is tight, everybody, what is it causing, everybody? It is causing superior oblique to remain contracted. That means superior oblique cannot relax because it is congenitally tight. Yes, it cannot relax. When superior oblique cannot relax, its antagonist, I hope you understand which law I am using here. Its antagonist, that is inferior oblique, cannot contract. Do you understand what I am saying here, everybody? Which law am I using, everybody? Which law am I using, everybody? Sherrington's law. Yes? Sherrington's law of reciprocal innervation. For one muscle to contract, its antagonist has to relax. Because superior oblique cannot relax, so inferior oblique cannot contract. Because inferior oblique cannot contract, the patient is unable to perform elevation in adduction. I hope you remember the clinical feature of inferior oblique. The clinical action of inferior oblique, everybody, that is elevation in adduction, up and in, everybody. Superior oblique was depression in adduction, inferior oblique was elevation in adduction. Am I absolutely clear? Now the only point to note here after all this story is, the problem is in which muscle, you will say? The problem is in superior oblique. But the manifestation is occurring in which muscle, everybody? Inferior oblique. That is the only thing you want to remember. A lot of students only remember that Brown syndrome is due to some problem in the superior oblique. So when the question comes, they answer clinical features of superior oblique palsy. Yes? But it is a restrictive squint. One muscle unable to relax, antagonist unable to contract. Okay, everybody? Done? That's simply Brown's syndrome. Now, if I show you the image for this, everybody, let's see this image. Again, everybody, I want to focus on this green box straight away for you. In this green box, what is occurring in the right eye? Right eye is trying to look here. Here means it is trying to elevate in adduction. Yes? Is it able to do so? No. Look at the left eye, everybody. Left eye is doing this action. That means elevation in abduction. Elevation and abduction is occurring properly, but elevation in adduction of the right eye is not able to occur. Yes? So there is restriction of this motion, and that is why I diagnose it as a case of Brown's syndrome. Am I clear to everybody? Are we absolutely clear? See again, adduction occurring but elevation not occurring. Compare it to the other eye. See here, everybody, in this, both the eyeballs are elevating and adducting and abducting both. So there is no problem here, but there is problem here. So this is right eye Brown's syndrome. No confusion? Done, everybody? These are the two simple photographs I can show you from restrictive squint. Please do remember these. Very simple questions get asked from these topics. Done? Now that we are done with incomitant squint, everybody, the question that you should all be asking yourself is, we understand that the nerves control the movement of the muscles. Yes? But how do the nerves get controlled? Am I confusing you? Yes, you should be confused. That's what I'm trying to ask you. When I look towards the left side, my left eye is lateral rectus contracting, sixth nerve. My right eye is medial rectus contracting, third nerve. So how are sixth nerve and third nerve able to act together? That means there has to be some supranuclear control of movement, or as I call it, gaze control. There is something in the brain which is controlling these nerves to act together, which can lead to gaze palsy. As we saw in sixth cranial nerve palsy, there was horizontal gaze palsy. So that is what we are trying to understand here, the supranuclear ocular movement control, right? Now, obviously the nuclear control or the gaze control will be from the cerebral cortex. This gaze control from cerebral cortex can be divided into two. From the frontal cortex and from the occipital cortex. Frontal cortex helps in the initiation of movements called as saccades, whereas occipital cortex initiates what, guys? Pursuits. Okay. Now what is the difference between these two words, pursuits and saccades? See, for any kind of vision, these are the two movements that our eye performs. Saccades are basically what we call as gaze. Let's say there is something which passes suddenly on your left side. What you will do? Okay. Your eyes will suddenly move towards the left side like this. There is something which passes over your head. You will suddenly look up. Okay. So this rapid involuntary movement, everybody, this is called a saccade. Now, let's say you are traveling in a car and there is a bus on your left side. That bus is crossing you. You are gazing on the bus and you are following that bus as it crosses you. So this is a following movement, everybody. This is a voluntary movement which is slow and which follows an object, and this is called a pursuit. Am I clear to everybody? So saccade is what, everybody? Saccade is a rapid fixating movement, whereas pursuit is a slow voluntary following movement. When we are talking about gaze, everybody, we are not talking about pursuits. I hope you understand. Gaze means to look towards the right side, left side, upside or downside. We are talking about saccades. Okay. So these saccades, I am dividing into two: horizontal saccades and vertical saccades, or what I can call horizontal gaze or vertical gaze. Horizontal saccades are controlled contralaterally. Vertical saccades or vertical gaze is bilaterally controlled, whereas pursuits are ipsilaterally controlled. Am I clear to everybody? More we will discuss a little later on. Just remember this much now: saccades means gaze, horizontal or vertical. Horizontal is contralateral controlled and vertical is bilaterally controlled. Am I absolutely clear about this much, everybody? Yes? Now that we know that we have two topics to discuss, the first topic is horizontal gaze, the second topic is vertical gaze. First of all, let's start with the more important topic on which questions are asked, that is horizontal gaze. So, the topic is horizontal gaze pathway, guys. Okay? You will see an image. This is the image of horizontal gaze pathway. Now, when we see this image, we see that there are two eyes. This is my right eye. This is my left eye. And in these two eyes, one muscle is marked each. Left lateral rectus, right medial rectus. What do I mean to show by this? Everybody see both the eyes. Left lateral rectus will cause abduction. The left eye will abduct, move towards the outer side or the left side. Right medial rectus will cause adduction. Right eye will move inside or towards the left side. So if you understand, this pathway is ultimately for which gaze, everybody? Left gaze. Both the eyeball looking towards the left side, which is using two muscles, left lateral rectus and right medial rectus. Am I clear to everybody? There will be an opposite similar pathway for right gaze, in which the muscle control will be right lateral rectus and left medial rectus. Am I clear? So left gaze pathway is being shown and discussed here. So everybody, left gaze pathway gets initiated from contralateral side. Please remember, horizontal saccade, contralaterally controlled. Contralateral side. So what is the structure, everybody? FEF. Frontal eye field. Okay? The right frontal eye field will start the signal for left gaze. The signal will travel towards the left side and it will reach a structure which is called as PPRF. What is the full form of PPRF? I hope through anatomy you may know. Para-pontine reticular formation. Para-pontine reticular formation. Please remember, I have already marked PPRF is the center for horizontal gaze. This is an MCQ in itself. What is the center for horizontal gaze? The answer is PPRF. Am I clear? So now, we have received the signal from the right FEF to the left PPRF. Am I absolutely clear, everybody? From the left PPRF, the signal is going to the left sixth nerve. From the left sixth nerve, it is going via the left sixth nerve to which muscle, everybody? Left lateral rectus. Left lateral rectus will contract, left eye will move towards the left side. From the left PPRF, the signal also crosses back over to the right side via the third structure, everybody. What is the third structure, everybody? This is the third structure, that is MLF, medial longitudinal fasciculus. Okay? Via the right MLF, the signal goes to right third nerve, and from the right third nerve it goes to right medial rectus. Right medial rectus contract, right eye move towards the left side. So through this pathway, both eyes are able to move towards the left side. Okay? Let's see again. Let's revise it. Number 1, frontal eye field. Of which side, everybody? Right side. From right frontal eye field, the signal goes to the left PPRF. Number 2, from left PPRF, it needs to go to both the muscles. From left PPRF, it goes to left lateral rectus. Very easy. From the left PPRF to go towards the right side, it has to go to the third structure, that is the right side medial longitudinal fasciculus. Then from right MLF, it goes to right medial rectus. So in effect, there are 3 structures which are controlling my horizontal gaze. Yes? Let's see. Left gaze is being controlled by number 1, right, or I can say contralateral frontal eye field. Okay? What was structure number 2? Left, or I can say ipsilateral PPRF. I hope you can see the diagram. I hope you can understand what I'm writing. Simple. And thirdly, the third structure is again right side. Right side again means contralateral MLF, medial longitudinal fasciculus. So left gaze is controlled by 3 structures. Am I absolutely clear? Contralateral FEF, ipsilateral PPRF, contralateral MLF. Why are we saying contralateral and ipsilateral? Because the gaze is left. If the structure is on the right, it is contralateral. If the structure is on the left, we are calling it ipsilateral. Absolutely clear, everybody? No confusion? Now, because there are 3 structures, there can be 3 lesions. Lesion number 1, right FEF. Lesion number 2, everybody, left PPRF. Lesion number 3, right MLF. Okay, everybody? Let's see what will occur in each lesion. Lesion number 1, right FEF. When right FEF is lesioned, everybody, the signal will not start. So neither will the left lateral rectus contract, neither will the right medial rectus contract. Am I clear to everybody? So what is occurring, everybody? Right FEF lesion, left lateral rectus unable to contract, right medial rectus unable to contract. Both eyes do not move towards left. Yes? So I say there is a left gaze palsy. Am I absolutely clear here, everybody? No confusion about this? Okay, very easy. Lesion number 2. Lesion number 2 was left PPRF lesion. Left PPRF lesion. Let's again go back. Left PPRF lesion. From the right FEF, the signal came to the left PPRF. But there is a lesion of the left PPRF. So will the signal be able to go to the left lateral rectus? No. Will the signal be able to go to the right medial rectus? No. Again, what is occurring, everybody? When there is left PPRF lesion, neither the left lateral rectus contracts nor the right medial rectus contracts. So again, there is what, everybody? Left gaze palsy. I hope we are clear, everybody. Okay. So what am I trying to say? FEF will lead to contralateral gaze palsy. Right, left. But PPRF will lead to ipsilateral gaze palsy. Am I clear to everybody? No confusion here? Now, let's move on to lesion number 3. Right MLF lesion. I hope you put your mind into this simple fact. Let's see the pathway again. From the right FEF, the signal starts, reaches the left PPRF. Okay? From the left PPRF, I'm showing in green color now, the signal is able to go here, here, and here. That means the left lateral rectus will contract. But when the signal goes here, it gets restricted. So which muscle does not contract, everybody? Right medial rectus. One muscle does not contract, one muscle contracts. Are you able to understand what I'm saying now, everybody? Yes? So what is occurring in right MLF lesion? Left lateral rectus is functioning. Am I clear? But right medial rectus is not functioning. Okay? So can I say, everybody, left or contralateral abduction is present, but right or ipsilateral adduction is absent? Now the only confusion I know a lot of you must be having is contralateral or ipsilateral. Please remember, the laterality is based on the site of lesion. The site of lesion is right MLF. That is why the left eye in this case is contralateral. So I am saying left eye is able to abduct. So contralateral eye is able to abduct. But the right eye, which is the ipsilateral eye to the side of the lesion, is not able to abduct. What is the end result? Left gaze defect. Now, why are we using the word defect here? I hope you understand. Because one eye is able to move and the other eye is not able to move. Am I clear to everybody? So, can I say now MLF leads to contralateral gaze defect? Right MLF, left gaze defect. Clear, everybody? This condition, lesion number 3. This is known as internuclear ophthalmoplegia. Internuclear ophthalmoplegia. The most common cause of this condition is multiple sclerosis. Okay, everybody, done. I hope you are able to understand it again. I will revise it for you quickly, everybody. The first structure is contralateral frontal eye field. For left gaze, right frontal eye field. Because it is right frontal eye field, when right frontal eye field will be lesioned, there will be left gaze palsy or contralateral gaze palsy. Structure number 2 is left PPRF for left gaze. That means ipsilateral PPRF. So when PPRF is lesioned, there is ipsilateral gaze palsy. The third structure is right MLF for left gaze. Contralateral MLF, which controls only one muscle, that is medial rectus. So there is contralateral gaze defect known as internuclear ophthalmoplegia. If still you have not been able to understand, let's see these photographs, and I hope after this you should not have any confusion whatsoever. Everybody, let's see the photograph A here, everybody. Now, this is my primary gaze. In primary gaze, do you see any problem? Yes or no? I will say this is absolutely normal. Both the eyeballs are looking straight. Now, this arrow is showing which gaze, everybody? Right gaze. Right gaze, normal or abnormal? Both eyes are able to move towards the right side, normal. This arrow is showing left gaze. Now, in left gaze, is any of the two eyes moving? No. That means there is left gaze palsy. So, my diagnosis is left gaze palsy. Now, left gaze palsy can be due to lesion of right FEF or left PPRF. Yes or no? Lesion number 1 or lesion number 2. Any confusion, everybody? Any confusion? I hope no. Now let's see the second image, everybody. In the second image, everybody, again, let's see the primary gaze. Any problem, any deviation? No. So the primary gaze is absolutely normal. Now let's see the second image. Again, which gaze? Right gaze. Right gaze, normal or abnormal? Again, normal. Now see the third image, left gaze. In left gaze, what are we able to see? It is already written. I will write it for you again. In left gaze, we see left eye abduction is present, but right eye adduction is absent. If right eye adduction is absent, that means right eye medial rectus is unable to contract. Only one muscle unable to contract. Right medial rectus is controlled by right MLF. That means my answer here is right MLF lesion. Am I absolutely clear about this? I hope there is no confusion in this. Yes, guys? Okay, very good. Now, third condition. Let's see the third condition here, everybody. Let's try to see it carefully. Primary gaze. Problem, yes or no? Everybody, by now you should be able to say normal. Now let's see the right gaze. In right gaze, what is occurring, everybody? What is occurring, everybody? Let's see this. Left eye adduction is not occurring. Yes or no? Whereas right eye abduction is present. That means left eye medial rectus not functioning. That means left eye MLF lesion. You will say it's just the opposite of the second image. No, let's see. Let's move on further. Left gaze. In left gaze, there is absolute palsy. So, this is a left MLF lesion. Yes, but along with this, I am saying left gaze palsy is due to left eye PPRF lesion. So, this is left eye MLF lesion plus left eye PPRF lesion. Okay, this is known as 1.5 syndrome. Why is this known as 1.5 syndrome? Everybody, left gaze is absolutely palsied, no action, number 1, number 2. Yes? Right gaze, one action occurring, one action not occurring. So, out of 4 possible actions, 3 are not occurring. Or I can say, out of possible 2 gazes, 1.5 gaze is not occurring. And that is why it is known as 1.5 syndrome. Okay, everybody? Am I clear? So, left MLF, left PPRF lesion leading to 1.5 syndrome. Done? Now I know some of you may be wondering why it could not have been left MLF plus right FEF. Guys, it does not occur. That's it. Left MLF and right FEF don't lesion together. One thing of the left side, one thing of the right side, they do not lesion together. What lesions together is both the things of the left side, that is the left MLF and the left PPRF, and that is why such a case is known as 1.5 syndrome. That's all. Am I clear, everybody? That's all about horizontal gaze palsy. I hope you've been able to understand the 3 structures, the 3 lesions, and all the names and photographs that I have shown you here. Okay, everybody? Done? Now, we will start with vertical gaze palsy. Vertical gaze palsy. A topic neither as important nor as difficult to understand as horizontal gaze pathway. Right? Vertical gaze pathway image has been given here, but this is actually not a pathway. This is just to make you understand the names of certain structures. The first name that I want you to focus on is RIMLF. Okay? RIMLF is said to be the primary center for vertical gaze. What is the full form of RIMLF, everybody? Rostral interstitial medial longitudinal fasciculus, MLF. Yes, RIMLF. Now, the right side RIMLF communicates with the left side RIMLF via posterior commissure. This becomes an important part because we need to understand that both the eyes will either go up together or down together. It is neither a unilateral action nor a contralateral action. It is always a bilateral action. Am I clear to everybody? So both the centers are communicating with each other. Now, these are the inputs which you see at the top. The RIMLF, which is the center, receives inputs for vertical gaze from the frontal and the occipital lobes and from the superior colliculus, or via the superior colliculus where the nucleus of the third nerve is situated. See, third nerve controls almost all the muscles for up gaze and down gaze, superior rectus and inferior oblique. Yes? Now, after reception of the inputs, the outputs from the RIMLF again go to 3 structures, as you can see. The first structure it is going to is labeled as INC. Very important. then the trochlear nerve nucleus, and then the oculomotor nerve nucleus. Trochlear nucleus will control superior oblique, oculomotor will control inferior rectus, inferior oblique, and superior rectus. I hope you understand. What is INC, everybody? INC is interstitial nucleus of Kajal. This is said to be the secondary center of vertical gaze. Question was asked 2 years back in AIIMS. Which of the following nucleus is helpful in vertical gaze? And the option was interstitial nucleus of Kajal, or rather just nucleus of Kajal was the option given in the question. So if you understand these names, you are able to answer such simple questions. That's it, everybody. Please remember the primary center. Please remember the secondary center. Please remember the importance of posterior commissure connecting both the RIMLFs. Done, everybody. Now, once we know this much, let's see the causes of vertical gaze palsy. Again, I am going to be superficial and brief here. Yes. Number one, the most common cause is distal basilar artery ischemia. Distal basilar artery ischemia. The second important cause is known as progressive supranuclear palsy. From the name itself, it is very clear that there is a palsy somewhere above the nucleus of the nerve, supranuclear, and it is a progressive condition. So the first question that the examiners ask you is, what is the initial gaze to be affected? See, vertical gaze is of two types, up gaze and down gaze. Yes, so they are asking you, which is the initial gaze affected out of the two? The answer, as you can see, I am writing on the screen, is down gaze. After down gaze, what gets affected, everybody? Up gaze. So the first to be lost is down gaze, and then what is lost is up gaze. Then we say global gaze palsy. It is a progressive condition. Even though we are listing it as a cause of vertical gaze palsy, ultimately it will cause horizontal gaze palsy also. And after that, the last moment which remains is convergence of both the eyes. Even convergence palsy occurs. So there is an absolute total ophthalmoplegia. None of the movements will occur. No eye will be able to move left, right, up, down, in, out, whichever way. Am I clear to everybody? No confusion about this. Done? Now, this usually occurs in old age. Okay? Then, third important cause is known as Perinaud's dorsal midbrain syndrome. Perinaud's dorsal midbrain syndrome. Going MCQ wise, simple questions to be answered. What is the site of lesion? The best answer is posterior commissure. Important structure. The link between both the centers, RIMLFs, is lost. What is the most common cause associated with Perinaud's dorsal midbrain syndrome? The answer is pinealoma, pineal gland tumor. Then, what are the presentations? Number one, there is some problem with posterior commissure. So there has to be some problem with vertical gaze. So we say it presents with up gaze palsy. Secondly, everybody, there is something called as Collier's sign which is seen. Collier's sign is called as eyelid retraction. Retraction, the upper eyelid moves up. Okay, just like we see in thyroids associated ophthalmopathy known as, you know the sign, I hope. Yes. So the same thing we call as Collier's sign in Perinaud's dorsal midbrain syndrome. Thirdly, everybody, there is light near dissociation. light reflex is lost, near reflex is still present. Somewhere, if you see, almost all the clinical features are somewhere related to problems of the third nerve. See, the output has to go to third nerve. The major work of the up gaze is done by the third nerve. So it presents something like that, just to remember, everybody. Am I clear to everybody? No confusion. That's all about the very simple and a topic which you need to mug up basically, that is vertical gaze palsy. Okay, everybody? Done? So now we move on to the third group of squint, everybody. And I say comitant squint. Incomitant, both variations done. So now we move on to comitant squint. Comitant squint, guys, if you remember, was when the deviation remains constant in all directions of gaze. Comitant squint usually presents as esotropia, which we can also call as convergent squint. I hope this name doesn't trouble you. ESO means inward. Inward means if both the eyes are coming in, basically that both the eyes are converging. Yes. So usually this presents as esotropia. So we are basically discussing esotropic comitant squint. Now, this comitant esotropia can be divided into two types: accommodative and non-accommodative. Accommodative comitant esotropia can further be divided into two types: refractive and non-refractive. Okay? Don't get confused, very easy. As soon as I say accommodative squint, which is refractive, do you remember something? Does a bell ring in your head? Refractive means due to some refractory error. Due to some refractory error, esotropia occurring, which is called as accommodative. Can I write again? Hypermetropia leads to esotropia. Haven't we discussed this already, everybody, as part of the second test when we were calculating the visual acuity? Uncorrected hypermetropia leads to esotropia because of over-accommodation and over-convergence, known as accommodative squint. So, this is a very commonly asked thing. I'll just give you a mnemonic to remember this. So hyper. Because I shout a lot. Maybe in online teaching also I shout a lot, but in offline I usually do. So students call me hyper. So I said, okay, let's make it a mnemonic. So hyper. ESO is associated with hypermetropia. Okay, everybody? We've already discussed this, not going into the detail again. Now, non-refractive. Non-refractive is due to either increased convergence or decreased accommodation. Characteristically, the esotropia at near is more than at far point. At near point, the esotropia will be greater than at far point. Okay? Then, what is the treatment for this, everybody? The treatment for this is again spectacles. Bifocal spectacles, guys. Bifocal for near as well as for far. Or, in this case, we can give miotic drugs. Miotics like ecothiopate, or we can do surgery. Any of the two. I am just writing the name, guys. Nobody asked this condition in detail. That's why just being very superficial with it. Bimedial recession, or the other surgery is called as Faden surgery. Retro equatorial myopexy. Retroequatorial myopexy. Okay. So just remember some information. Usually the question comes from this point, that ecothiopate is used in the treatment of or Farden surgery by medial recession. These are the 2 points usually used as MCQ simple straightforward questions. Okay. Accommodative squint of 2 types, refractive, non-refractive. The more common, the more important being refractive, which I have explained to you in detail. Esotropia associated with hypermetropia. So hyper. Non-refractive, not that important. Now let's move on to the second group of esotropia that we have said, non-accommodative. So, non-accommodative esotropia. Non-accommodative esotropia is known as essential infantile esotropia. Essential infantile esotropia. As soon as we read this name, guys, we get to understand 2 points. Number 1, it is occurring in infants. And number 2, it is essential. Essential basically is trying to denote that there is no known cause for it. You rule out every cause, neurological cause, the accommodative cause, and once you are not able to diagnose it as any other thing, you call it essential, which is just happening on its own. Infantile esotropia. It is usually associated with latent horizontal nystagmus, to and fro movements horizontal. Secondly, inferior oblique overaction. Thirdly, dissociated vertical deviation. LID. Once a question on these associations has been asked in PGI exam, everybody. So latent horizontal nystagmus, inferior oblique overaction, and dissociated vertical deviation. These are the 3 associations. Apart from this, the major point in essential infantile esotropia is it is always large angle squint. Greater than 30 prism diopter. Greater than 15 degree or greater than 30 prism diopter. Why is it an important point, everybody? If we have listened carefully when we were discussing suppression and diplopia, everybody, ARC, everything. Large angle squint leads to confusion, 2 objects, 2 images, and that is why the deviated eye gets suppressed. Suppression leads to amblyopia, loss of vision without any organic cause. Now think about it, an infant, everybody, a 6-month-old, will get amblyopic in the deviated eye. The infant will lose the vision throughout life from one eye, which has no cause, so which has no treatment. Amblyopia, lazy eye is occurring. So that means as soon as I see this case, when I think about the treatment, my number 1 aim is to prevent the occurrence of amblyopia. Do you understand this? See, I know amblyopia can occur. Amblyopia will lead to loss of vision, so I want to prevent it. So how to prevent amblyopia? The first important treatment is occlusion therapy. Occlusion therapy. As a concept, we say we patch the normal eye. We patch the normal eye. Now the question comes, why are we patching the normal eye? Everybody. If this was the case, large angle squint, right eye was deviated 45 degree, I know right eye would have been suppressed. Why would the right eye have been suppressed? Because the brain wants to see one clear image. So instead what I am doing is, I am patching the normal eye. As soon as I patch the normal eye, everybody, the brain is only able to see one image, and that image is coming from the deviated eye. So the brain's problem is solved. The brain is seeing only one image. When the brain is seeing only one image, the brain will not suppress the deviated eye. And thus, amblyopia will not occur. But, if you think about it, if I patch the normal eye can't see anything. So, isn't there a risk of the normal eye actually undergoing amblyopia? My brain will say, it is always patched, it is doing nothing. Okay? So, what is the actual rule of occlusion therapy?
The actual method or rule of occlusion therapy is we occlude the normal eye for days, which is equal to age of child in years. Example, 2-year child, occlude the normal eye for 2 days. Followed by occlude deviated eye equal to 1 day. Am I clear to everybody here? Deviated eye will be occluded only for 1 day, but the normal eye gets occluded for number of days, which is equal to age of child. So, let's say in a 4-year-old child, 4:1. This is a cycle. It will keep on continuing. 4 days, normal eye gets occluded. 1 day, deviated eye gets occluded. Are we clear about this? No confusion? So that's the method of occlusion. Alternate occlusion is done. Okay, everybody? So that's our occlusion therapy to prevent amblyopia. That's the first way we can prevent amblyopia. But there is actually another way we can prevent amblyopia. The second way to prevent amblyopia is called as penalization. In penalization, we use atropine drops in the normal eye. Why do we use atropine eye drops? See, atropine is a mydriatic agent. It will dilate the pupil. Now let's say the right pupil of the child is dilated. Whenever the child will go into bright light, sunlight to play, the amount of light will not be able to constrict the pupil. So there will be photophobia that the child will experience. Due to the photophobia, the child will do this. Yes or no? When lots of light falls onto your eyes, you have to close your eye voluntarily. Yes? So basically, atropine is another way to voluntarily be able to occlude the deviated eye. Am I clear to everybody? Am I clear? Okay. Now, after we have prevented amblyopia, the main treatment you can say is surgery. So what is the name of the surgery, everybody? Recession and resection. Recession and resection. Now, what is the meaning of these two words? Recession and resection. Again, English, everybody. Focus on the word resect. Resect means to cut. When we are cutting something, we are shortening, everybody. We are cutting a muscle, we are making the muscle short. By making the muscle short, we are actually increasing the power. The shorter the muscle, the more powerful. So I can say it is a strengthening procedure. Recession is absolutely opposite. Due to the COVID crisis, everybody is saying the economy is in recession. Recession means the economy is becoming weaker. Yes? So, recession is a lengthening procedure. When we lengthen a muscle, we are actually weakening a muscle. Okay? So, we are doing the surgery on two muscles. One muscle is being made weaker, the other muscle is being made stronger. Think about it. It is a case of esotropia, inward deviation. I want to pull the eyeball out. To pull the eyeball out, which muscle should be made stronger? Which muscle can pull the eyeball out, everybody? Lateral rectus. Yes? So that means I will actually do lateral rectus resection. And to leave the eyeball, yes, I will make the medial rectus weaker so that it leaves the eye. So medial rectus recession and lateral rectus resection. Pull the eyeball, lateral rectus, leave the eyeball, medial rectus.
So now that we have discussed the main types of squint, everybody, again go back to the classification. Paralytic done, restrictive done means incomitant done. Comitant we have just done. Yes. So 3 main groups done. If we go back to the classification, we have completed true squint or true deviation. Now what is left is everybody pseudo strabismus or apparent deviation. So that's our last topic in squint that we want to discuss. Apparent deviation. Okay. That means there is actually no squint. It just looks like squint. Let's understand first theoretically the reasons, and then let's see some photographs to understand whatever best we can in this. Now, pseudostrabismus can be divided into two. One we call as pseudo-esotropia, or I can say in simple words, apparent convergent squint. Yes or no? ESO means inside, convergent means inside. The second is pseudo-exotropia, which I will say apparent divergent squint. Okay? Am I clear to everybody? No confusion, I hope? Yes? Now, what are the causes of pseudo-esotropia? Let's write it. Number one, telecanthus. What is telecanthus? In simple words I am writing, then I'll explain later on. Increased intercanthal distance, that is ICD, with normal interpupillary distance, IPD. Okay? Number two, epicanthus. Epicanthus, a congenital nasal fold of skin connecting medial part of upper lid and lower lid. Again, I'll show you the photograph and make you understand this. Okay, everybody? Number three, myopia. These are the three causes of pseudo-esotropia. Now, to remember them, we have a simple mnemonic, guys. From ESO, I pick up S. That's the only letter which is different between ESO and EXO, yes? Telecanthus T, epicanthus E, myopia M, and the mnemonic becomes STEM. This is how I remember it. Okay, everybody? Esotropia S, telecanthus, epicanthus, myopia. You will never forget these causes. Okay? Now, let's move on to the causes of pseudoexotropia. Pseudoexotropia, number one, hypertelorism. What is hypertelorism? Increased intercanthal distance along with increased interpupillary distance. Okay, both are increased. The second cause is ROP, retinopathy of prematurity. And then the third cause is hypermetropia. These are the three causes, just mug them up, everybody. Yes? Now, once we have been able to complete this list, then what do we want to do? Then we want to be able to understand some of these. Let's first understand epicanthus. So let's see this image, guys. In this image, when you see there are two words written, one is epicanthus, one is telecanthus. Forget both of these words. Let's say this image comes in your examination and it is asked diagnosis. Okay? Now, as soon as you see this image, where does your mind go first, everybody? What do you think of first? As soon as we see this image, we think of esotropia. Yes or no? Yes? All of you thought about this, I hope. Yes? But is this a case of esotropia? That is the question. The answer is a big no. This is not a case of esotropia. If it is not a case of esotropia, it is what, everybody? So let me label it what we have been discussing, pseudo-squint. It is a case of pseudo-esotropia. Now the question comes, sir, if it is very easily evident to us that it is a case of inward deviation, why are you calling it pseudo-eso? So let's compare the child's image and my eyes, everybody. In my eye, you can see my eyelids meeting at two corners. My upper eyelid and lower eyelid touch at this corner. This point is called as lateral canthus, and this point is called as medial canthus. Medial canthus, lateral canthus. In the child's eye, you will be able to see that the medial canthus should have been somewhere here. See, this is how the eyelid should have been. This is how the eyelid should have been. Yes? But there is an extra fold of skin. If I color this with blue, everybody. This is an extra fold of skin, everybody, which is connecting the upper eyelid to the lower eyelid, and in effect, it is covering the medial part of the eyeball. And it is epicanthus, everybody. So this is the epicanthal fold of skin which is making the eye appear esotropic. Actually, the eye is not esotropic. If I were to take a, let's say, a scalpel and cut this piece of skin, everybody, then the eyelids would have become like this, and you would have been able to see the white sclera behind here, so that white on right side and white on left side of the lateral and the medial side would have become equal, and the eyes would not have looked esotropic anymore. This is just a facial feature, guys. This is not a disease. A lot of the Japanese population are born with this kind of a facial feature. We don't treat it. There is no consequence because there is no squint. I hope you understand this. Now that we know all the types of squint, guys, and we are confident in it, I will like to take 5 minutes here and teach you a related topic which presents with squint but which is actually not a part of squint. A topic which usually acts as a confounding factor when asked. We are not able to place it in any of the chapters or groupings, everybody. Okay? A topic which can be taught to you in pharmacology, which can be taught to you in medicine, but which I will also teach you in brief, everybody. What we are discussing here is ocular myopathies. Now, ocular myopathies, from the name itself, it is very clear. Some problem in the ocular muscles, which is leading to some problem in my ocular movements. Okay? Now, the first condition I will like to discuss here is myasthenia gravis. Now, all of you know about myasthenia gravis. I'm not going to go into the detail of what is myasthenia gravis. Post-synaptic cleft problem where the ACH receptors are decreased due to some auto-antibody mediated, B-cell mediated damage, everybody. We know that. Due to that, there is fatigability. The fatigability is worse at the end of the day. In the morning, the muscles are functioning, but as the ACH gets on depleting, everybody, tiring occurs. Yes? Now, what we are discussing is the ocular clinical features of myasthenia gravis. So the first ocular feature is it is affecting the extraocular muscles, the skeletal muscles, right? So because my LPS gets affected, we have ptosis. Okay, the ptosis is usually bilateral and asymmetrical. So usually you will see one of the eyes highly ptotic, and whereas the other eyelid is maybe marginally ptotic. It is bilateral, but it is asymmetrical. Secondly, everybody, you will see ophthalmoplegia. Now, we all know ophthalmoplegia means restriction of ocular movements. Okay. So ophthalmoplegia means restriction of ocular movements. This ophthalmoplegia may be partial or it may be complete or total also. What also occurs along with is diplopia. Now, diplopia can occur actually due to both the causes listed above. Ptosis can lead to diplopia or even ophthalmoplegia because the eyeballs are not moving. Let's say it is not able to move outside. There is restriction of abduction. It will lead to diplopia as we have seen. Yes. Lastly, there is something called as the Cogan lid twitch sign. What is Cogan lid twitch sign? When we are looking down, everybody look at my face. My chin is straight. When I'm looking down, my eyelids are also down. When I look up, my eyelids go up. But in case of myasthenia gravis, when you are looking down, down gaze, and then when you look up, your eyelids go further up, everybody. So there is an upshoot of the eyelids when you change from down gaze to primary gaze. Okay? So upshoot of upper lid when changing gaze from down to primary position. I can't demonstrate. I don't have myasthenia gravis, guys, but I hope you are able to understand. The eyelid just moving up, but it moves up further, up shoots, and then becomes normal, everybody. That is Kogan lid twitch sign. Okay. Now, apart from these things, what is important is a very important test, which I can say a test for diagnosis. Now, there are two things which we do as ophthalmologists when we suspect myasthenia gravis in a ptotic patient. So basically, this is differential diagnosis of ptosis or of squint, whichever way you can say. So the first test we do is ice pack test. You apply ice pack over the ptotic eyelid. Over a period of 20 minutes, it will improve. Okay. On resting, it will improve. Or the second test, which you may have read, may have come across in pharmacology. If not, I am teaching it to you guys. Tensilon test or hydrophonium test. Okay. Now, why I said pharmacology? I hope you understand because of the word hydrophonium, the drug hydrophonium. Now, what is hydrophonium? What is hydrophonium, guys? Hydrophonium is a, yes, short-acting anticholinesterase. Yes. So when we give 0.2 milligram of hydrophonium, it will lead to increased levels of ACH at cleft, the postsynaptic cleft. Yes. And thus what will be the end result? It will improve my ptotic eyelid. Yes. So that is how I am confirming everybody. I am confirming my diagnosis of case of myasthenia gravis, that on giving an anticholinesterase agent, my ptosis is improving. Yes. Let me show you a photograph. See everybody, photograph A, you can very ably see right eye is highly ptotic. Then we have given post-injection, I can say. When we have given an injection, after around 5 minutes, everybody, we can say that the ptosis has improved. Okay. So this is a clear-cut case of a myasthenia gravis patient. I hope there is no confusion. Ocular myopathy. Let's move on to the second ocular myopathy. The second ocular myopathy is CPEO, the full form being chronic progressive external ophthalmoplegia. CPEO. A lot of things are clear from the name itself. Ophthalmoplegia means restriction of movement. Progressive means it will progress, and it is a chronic condition. CPEO, as you may know, is a mitochondrial disorder. Okay. It may be idiopathic. It may occur as part of something known as Kearns-Sayre syndrome, or it may be associated with oculopharyngeal dystrophy. Okay? It is a mitochondrial disorder. On histology, you get the red ragged fibers, if you remember. Yes? Then, what are the ocular clinical features? See, again, we are talking about the external muscles, extraocular muscles, everybody. Ptosis will be there, yes. Ptosis is always the first presenting sign. So again, as a differential diagnosis of ptosis, we need to be aware of this ocular myopathy, everybody. Secondly, everybody, ophthalmoplegia is in the name. As I explained to you, it is in the name. So there is restriction of ocular movements, but it is progressive. So progressive means, first of all, upward movement is lost. Then lateral movements are lost. And then the down gaze is lost. Okay, so that is how it progresses. Upward, lateral, and then down, everybody. So triangle basically. Upward, then lateral, then down. First this, then this. Okay. Then thirdly, everybody, diplopia. That is how basically you can differentiate it. In the question from myasthenia gravis, there is no diplopia in cases of CPEO. CPEO does not present with diplopia, whereas myasthenia gravis will present with ptosis, ophthalmoplegia as well as diplopia. plus the differentiating factor, that ptosis will be the first sign in cases of CPEO. In cases of myasthenia gravis, there is no such relation. Ophthalmoplegia may precede ptosis, ptosis may precede ophthalmoplegia, but the defining feature will be that myasthenia will get worse in the evening. Nothing like that in CPEO. I hope we are able to clarify these two simple topics in association with our squint, everybody, so that we are able to answer all questions where these options or these kind of presentations may be given to us as confounding factors, everybody. That's all about our extended squint also.